Good evening, and welcome to the Penn Transplant Virtual CME Series. I'm Margaret Lead, Senior Transplant Physician Liaison at the Penn Transplant Institute. And before we get started, I'll be quickly reviewing CME information and introducing tonight's speakers. Tonight is the fourth event in our series, and this evening we'll be offering a presentation titled Critical Vaccination and Transplantation Update for Community Partners, Managing COVID Vaccinations and More. The session will be recorded and made available online. However, credit is only available for those participating in the live session. Regarding continuing education credit, this evening's event will provide one AMA PRA Category 1 credit for physicians and one NCPD hour for nurses. After the session, you will receive an email from the Penn CME office with guidance on completing the evaluation and receiving credit. There will be a time set aside at the end of the presentation for Q&A. At that time, you can unmute your mic and ask your question. Our faculty will also be monitoring the chat if you'd like to ask your question during the presentation in the chat section. The faculty members presenting this evening are Dr. Emily Blumberg and Dr. Ingi Lee. Dr. Blumberg is the Director of Transplant Infectious Diseases at the Penn Transplant Institute. She has been on the front lines as the transplant community has navigated COVID-19 and worked tirelessly to help keep transplant patients safe throughout the pandemic. As a nationally recognized expert in infectious diseases, Dr. Blumberg has served as the president of the American Society of Transplantation and had her work published in numerous important publications. We are fortunate this evening to have Dr. Blumberg share her knowledge and expertise regarding vaccinations and transplantation. Dr. Blumberg is joined tonight by Dr. Ingi Lee, Assistant Director of Transplant and Infectious Diseases at the Penn Transplant Institute, where she has served patients for 6 years. Her work has been published in several important publications, including The Lancet, Transplant Infectious Disease, and the American Journal of Transplantation. Welcome, Dr. Lee.
Hi, thank you so much. I'm just going to share my screen. So thank you so much for joining us today as we discuss the importance of vaccination in our transplant population, both the transplant candidates and the recipients. I'm going to start off the presentations with the discussion of non-COVID vaccines, and then Dr. Blumberg will discuss COVID vaccinations. So financial disclosures, I'm the principal investigator for a clinical trial with Mrna here at Penn. So I wanted to start off with just a little bit of vaccine history, because vaccines, as you know, are one of the most important public health achievements that we've had to date. It's resulted in a significant decrease in mortality with millions upon millions of lives saved, and really has helped to increase the lifespan to what we currently have. And one of the key figures when we think about vaccines is a scientist that's pictured above, who I don't think is as well known as he should be, given that he's credited as having saved more lives than any other scientist in the 20th century. His name was Maurice Hillman. He was the head of Mrna Vaccines, and he created over 30 vaccines, including many of the ones that we currently use as part of childhood vaccination. And so when his daughter, Jerry Lynn, who's pictured below, was 5 and had mumps, she had the back of her throat swabbed and isolated mumps, and he created the mumps vaccine that's part of MMR. And because of scientists like Dr. Hillman, we have these really amazing vaccines that have changed the landscape of different illnesses. And what I like here on the right is a picture from the CDC that gives you an idea of the estimated annual morbidity in the US of different illnesses, both before and after the introduction of different vaccines. And you can see here that vaccines have really dramatically decreased and sometimes eliminated these diseases that we see here in the United States. So they've done a very tremendous job. And we know that there are certain populations that are particularly vulnerable and could benefit from vaccines. And these include our immunocompromised patient populations. So organ transplant recipients, as you know, after their transplant are placed on immunosuppression, and this can increase their risk for infection. And in the next couple of slides, I just wanted to highlight how much greater risk they potentially are at and how vulnerable they can be. So this first study is by Von Alst and colleagues. It's a systematic review and meta-analysis that looked to better characterize the incidence of invasive pneumococcal disease in immunocompromised patients. And they did subgroup analyses looking at the incidence in particular groups, including organ transplant recipients. So they found 4 papers that met the criteria and estimated the incidence to be 465 per 100,000 person years, And so to give you something to compare that to, so what's typically reported in the general population is about 10 per 100,000 person years. So they're at 46 times greater risk for invasive pneumococcal disease. When we look at herpes zoster, we sort of see something similar. This was a study that was done at Penn and colleagues. It was a meta-analysis where they looked to characterize the incidence of HC in adult organ transplant recipients. And they looked through the literature as well as supplementing using data from their own university at Yonsei. And they estimated the incidence to be about 9%. So to compare this in the general population, it's about 0.3%. So again, much higher due to their levels of immunosuppression. And then what they did is they wanted to get a sense if the incidence of HC varied depending on which organ they had transplanted. And what they found is that the highest risk was in the heart transplant recipients, followed by lung, which is not unexpected because usually these are the patient populations, the transplant populations that are on the highest levels of immunosuppression. And among organ transplant recipients, the lowest risk was in the kidneys because with time, typically they're on the lowest levels. Of course, their levels are still higher than the general population, but it was the lowest of the transplant group. And the last study that I just wanted to review is a 5-year prospective multi-center evaluation of flu in both stem cell and organ transplant recipients. When they looked at organ transplant recipients who were diagnosed with flu, they found that 20% had lower respiratory tract infection, 69% required hospitalization, of which 11% were admitted to the ICU, and the 30-day all-cause mortality was about 3.2%. So these figures are much, much higher than what we see in the general population, where, for instance, mortality is typically estimated to be between 0.1 to 0.2%. And when they looked at factors that might be associated with flu, with pneumonia at the time of flu presentation, or factors that might be protective, they found that 2 things were protective. 1 is getting early antiviral therapy, and 2 was getting the flu vaccine in the same season. So those patients who were vaccinated but ended up getting flu had much lower rates of pneumonia than those who had not. So I hope in the last couple of slides, it was able to show you how vulnerable these patient populations are and that they're at risk for infection and that we have this important tool, vaccination, that can try and decrease this risk. So it's really important that both transplant candidates and recipients be up to date on their vaccines, but it's not just them because we really want to create this bubble of protection around them. So anyone who has a lot of interactions with them, close contacts, family, and us healthcare workers, it's really important that we are up to date on our vaccinations as well. And when we think about vaccination and transplantation, ideally those discussions should start prior to transplant because we know that the way that vaccines work is not just by getting the vaccine, but it's by the body's response to the vaccine, the immune response. And we know that that immune response can be blunted post-transplant. So there's a better vaccine response when given pre rather than post-transplant. And even in the course of organ disease, there's a better vaccine response earlier in the course. So somebody who has early stage CKD will have a much better response to a vaccine than, for instance, someone with end-stage renal disease on dialysis. And lastly, there are certain vaccines that we cannot give post-transplant. So live virus vaccines are contraindicated post-transplant because of a potential safety concern that in the setting of augmented immunosuppression, it could cause vaccine-related disease. So our chance to give them these vaccines, if they're not immune, is prior to their transplant. Although we know that vaccination is so important in both our candidates and our recipients, we also know that there is suboptimal vaccine uptake. This study by Dong Li and his colleagues was performed to get a sense of vaccine uptake in their kidney transplant candidates listed at an academic center between 2010 to 2014. They did chart review and did a self-reported questionnaire as well. And of the 362 patients who were included, 46% were on the transplant list and active on the transplant list. And you can see here, a majority of the patients were on dialysis, either hemodialysis or peritoneal dialysis. And so these are people who have multiple interactions with the healthcare system and with different healthcare providers. But you can see here that the vaccination rates are low. So 35% had gotten Pneumovax, 55% had gotten flu vaccine for that season, 2.5% had gotten tetanus, and 6.9% had gotten herpes zoster vaccine. And when they looked at hepatitis B surface antibody positivity, 58% were positive. When they did subgroup analysis comparing patients who were on dialysis versus not on dialysis, they found that those on dialysis had higher rates of pneumococcal vaccine and had higher Hep B surface antibody positivity, because oftentimes these vaccines can be part of dialysis care and funded as part of dialysis care. But even with that, the rates are lower than we would like to see. So what are the potential barriers to vaccination? So there are probably a couple of different things at play. There's not just one reason. One question that comes up is who is responsible for vaccinating the patient? Oftentimes these patients have multiple different providers, both locally and also at their transplant center. And sometimes it's hard to know who's really taking ownership of this issue and making sure that they're up to date. Sort of compounded with that is that it can be difficult to get vaccination records because they could get it at multiple different locations. Like they could get their flu shot from their primary care doctor, then been hospitalized after stepping on a nail and gotten Tdap there, and then gotten their COVID vaccines at a local pharmacy. So trying to get all those up-to-date records can be time-consuming and difficult. Some of these patients can have active medical issues and high acuity of care. And this could lead to deprioritization of preventative measures like vaccination. And also there can be questions regarding vaccine administration, like which vaccines do we give, when do we give it, and the safety of vaccines. And so I hope with our talk today that we're able to answer any questions that you may have about vaccine administration and potentially remove that barrier. And we hope that with these talks, we just, again, stress how important it is to vaccinate this patient population, because it's a very important way that we protect them and enable them to continue to do well. So a couple of things to consider, general guidelines about vaccination and transplantation. One is that any vaccines that require multiple doses, like Shingrix or Hep B, you can always start it prior to transplantation, and then whatever doses you don't complete can be given post-transplant. Prior to transplant, if possible, we try to complete any inactivated vaccines at least 2 weeks prior to try and give them a chance to have a robust immune response. And for live virus vaccines, we try to complete them at least 4 weeks prior to transplant to prevent potential vaccine-related disease. So if I find that one of my patients, my transplant candidates, needs a live virus vaccine, I usually touch base with the transplant team to make sure that's okay and they have that time frame to safely administer it. Post-transplant, we talked about live virus vaccines are contraindicated. And for inactivated vaccines, we typically wait 3 to 6 months post-transplant. And here at Penn, we tend to wait a little bit longer, around 6 months post-transplant, because typically these patients are on high levels of immunosuppression after their transplant. And if they're continuing to do well, the transplant teams will taper down their immunosuppression. So with time, our hope is that they will have a better response to the vaccine. However, there are a couple of vaccines that we consider giving earlier than this time frame, at least 1 month post-transplant. And that really has to do with consideration of risk benefit. We saw during flu, flu is so prevalent, it's easily transmissible. And we saw in the earlier study that it can be associated with significant morbidity and mortality in patients. And so to try and give them some protection, even though we know that it might not be ideal, we will consider giving it to them at least 1 month post-transplant. And the same thing with the COVID vaccines. One of the questions that comes up is vaccination and rejection. So there is a theoretical concern that because vaccines induce an immune response, there's a concern that could it potentially trigger rejection? And although it is a theoretical safety concern, it hasn't been fully borne out in the literature. And I just wanted to give you one example of a study that shows this. So this was a study that looked at flu vaccine and whether it should be given to heart transplant recipients. And they basically compared centers that recommended flu vaccine to those that did not recommend flu vaccine because of concern for rejection. And they looked at 3 different time periods. So here is 4 months before flu season when flu vaccines are given. These are the 4 months when during flu season, and then the 4 months after. And they found that there were no difference in the rates of rejection between those centers that recommended flu vaccine versus those that did not. So now that we're thinking about which vaccines to give our transplant candidates and our recipients, I just wanted to go through a couple of resources for you. So the first is, of course, Cdc Acip Recommendations. This is a nice table that I like that sort of summarizes the vaccines that you should consider. And it's separated by medical condition or other indications. So here we see a column for immunocompromised patients, then for end-stage renal disease, heart, lung disease, and liver disease. So this was last updated in 2021. So there are a couple of updates, which I'll go through with you in the next couple of slides. There's also the American Society of Transplantation ID Community or Practice Guidelines, which are updated every few years. The last time was in 2019. So their ID guidelines, they were published in their entirety in clinical transplantation, and there's a chapter on vaccination. And this table sort of outlines the vaccines to consider. It gives you an idea if it's live attenuated or inactivated, which ones you can give before, which ones you can give after transplant, and which ones where you could potentially evaluate for a serologic response. So now that we've taken a look, an overview of the different vaccines you want to consider, I just wanted to talk about the vaccines in a little bit more detail. So the first one that I'm going to start off with is with flu. So I know in the last couple of years, flu has really been eclipsed by COVID, but it's a really important respiratory infection to think about. And here you can see how prevalent flu can be. So it gives you an idea of the US influenza burden by season over a 10-year span from 2010 to 2020. And you can see there's sort of variability in the rates of infection and hospitalizations and deaths, and that happens to do with whatever strains are circulating, which vaccines are available, if they're a good match for the viruses that are circulating in vaccine uptake. But over this period of time, the CDC estimated that flu resulted in 10 to 40 million illnesses, 150 to 700,000 hospitalizations, and 12,000 to 52,000 deaths annually between this time frame. So the way that flu is spread is via respiratory droplets with an incubation time of 1 to 3 days. And typically we think about flu during the flu season, like late fall, winter, and early spring. So it sort of like goes up and then comes back down. But what's interesting is when you look at this year's flu season, it's a little bit different, I think, because of changes with mandatory masking. And then after masking was lifted, we see that the curve looks a little bit different this year. And there have been more flu cases further out than we've seen in previous years. And we saw that organ transplant recipients are at increased risk for complications. So those can include lower respiratory tract infections like viral pneumonias, bacterial pneumonias, myocarditis, pericarditis, and it can also be associated with rejection. We know that flu has high mutation rates. There's an antigenic drift that occurs yearly. And because of that, that's why we typically get a new flu vaccine every year. So the CDC recommends yearly vaccination for everyone at least 6 months of age or older. And in older adults, 65 years of age and older, there is a high-dose flu vaccine, high-dose Fluzone. And the reason that it's recommended is because we know that our immune system wanes as we get older. And so the idea is to give more antigens, so it's 4 times the amount of antigen as standard dose flu vaccine, to elicit a better immune response that could hopefully be associated then with a better efficacy. And so when we think about that, in our organ transplant population, there's that same concern that they may not respond as well because they're on immunosuppression. And so we try to give them high-dose flu vaccine, high-dose Fluzone, if it is available to them. If not, then they should definitely be vaccinated with standard dose flu vaccine. Again, live attenuated flu vaccine is contraindicated in organ transplant recipients. And this is one of the vaccines we try to give earlier post-transplant, at least 1 month post-transplant, because we know that in the organ transplant population, that it can reduce infection as well as complications. The next item that I want to talk about is pneumococcal vaccines. So Streptococcus pneumoniae can cause pneumonia, and it can also be associated with invasive pneumococcal disease where you find in normally sterile sites, like a bacteremia, endocarditis, or meningitis. When we look at the incidence of invasive pneumococcal disease, it has this U-shaped distribution. So you can see here, there are high rates in the very young, then it starts going down and it increases again. And when we look at mortality, it's particularly high among older patients. Other risk factors include comorbidities that we see in both our organ transplant candidates as well as recipients. And we saw from that prior study that organ transplant recipients have a 46-time greater risk than in the general patient population. So we have good vaccines for the prevention of invasive pneumococcal disease. So these figures were put together by the CDC. On the top here are rates of invasive pneumococcal disease among children less than 5 years of age from 1998 to 2015. And then this is rates of invasive pneumococcal disease among adults greater than 65 years of age. And what we see during this period, so I'll just go over what these different colors mean. So in red are invasive pneumococcal disease due to one of the serotypes that was in the original vaccine, conjugate vaccine PCV7. In blue are rates of invasive pneumococcal disease due to one of the serotypes that was in Prevnar 13, but not part of PCV7. And then in green here are non-vaccine types. So you can see that after PCV7 was introduced, the incidence of invasive pneumococcal disease really went dramatically down from about 80 per 100,000 person years down to less than 1. There was a little bit of an uptick in invasive pneumococcal disease due to one of the serotypes that was not found in this vaccine. And then when PCV13 was introduced here, again, there was a sharp drop from an incidence of about 15 per 100,000 person years to, again, less than 1. And what was interesting is that when you look at adults greater than 65 years of age, you also see that similar drop. And that might have to do with herd immunity and decreased transmission due to herd immunity. And then you can see here that there was a slight uptake in invasive pneumococcal disease due to one of the serotypes in PCV13. But again, once it was introduced in children, you saw the drop in the incidence of these cases. So there have been updates to the pneumococcal vaccines this year. What hasn't changed is who the CDC is recommending it for. So the CDC recommends pneumococcal vaccine for anyone 65 years of age or older. And then in adults 19 through 64 years of age with certain underlying medical conditions, which includes our organ transplant candidates and recipients. The reason for these updates is because there are 2 new pneumococcal conjugate vaccines. There's PCV20, which is the new Prevnar 20, which honestly I think is the one that's going to have the most uptake. But there was also another PCV vaccine, PCV15 Vaxneuvance that was created. But I think ultimately we'll move towards using PCV20, and I'll sort of explain to you why. So for those who have never received a pneumococcal vaccine, what they recommend is to get 1 dose of PCV20, Prevnar 20, and then you're done with your vaccines. If for some reason PCV20 is not available and you have PCV15, then you can use that, and then it's followed by a dose of Pneumovax at least 1 year later. And that interval is then decreased to 8 weeks in adults with immunocompromising conditions, cochlear implants, or CSF leak. And then once you're done with those vaccines. For those who previously had Pneumovax but haven't received a conjugate vaccine, you can give them either PCV15 or PCV20, and then you're done. What is a little bit more tricky is in patients who've previously gotten Prevnar 13, but who have not received all their recommended doses of Pneumovax. And you can see here the number of doses of Pneumovax sort of depends on your age and the underlying medical condition. So if you're old, above 65 years of age, then you just get 1 dose of Pneumovax and you're done. For CSF leak or cochlear implants, it might be 2 doses. For immunocompromising conditions, it might be 3 doses. This can be a little bit confusing when you're putting it into practice, but what I like is this comment that was listed here by the CDC. So for adults who have received Prevnar 13, but have not completed their recommended pneumococcal vaccine series with Pneumovax, one other option is just to give them a dose of Prevnar 20. Prevnar 20 can be used if Pneumovax is not available, and once it is given, then the conjugate, then their pneumococcal vaccination is complete. So I think PCV20 is really going to be simplifying the pneumococcal vaccine guidelines. So the next thing that I wanted to discuss is shingles. So shingles is caused by VZV, Varicella Zoster virus, and VZV is associated with two distinct clinical illnesses. So the primary infection is what we see here with chickenpox, where you have this vesicular, diffuse vesicular rash, and it's typically associated with systemic symptoms like fevers, malaise, sore throat. And then after that initial infection, then the VZV virus travels down the nervous system and establishes permanent latency in the dorsal root ganglion. So once you have chickenpox, the VZV virus stays with you for the rest of your life. And at some point in the future, it can reactivate to form herpes zoster or shingles, which the classic presentation is this like dermatomal, localized rash without systemic symptoms. Although of course in our immunocompromised patients, there can be atypical presentations or it can be more severe. So for those of us who've had chickenpox, there is a significant risk of developing zoster. It's about 30% lifetime risk, and those that are at least 85 years of age, that risk increases to about 50%. So the risk factors include previously having had chickenpox, increasing age, and here we see a nice graph that was put together looking at rates of HC in light blue here, plotted against each decade of life. And you can see that it really does increase and starts to take off at about 50 plus years of age. And the reason why, again, is that as we get older, our immune system wanes. We have decreased T cell immunity. And so that can cause reactivation of VZV. And so when we think of that as a risk factor, it's not surprising that immunocompromised patients are also at risk. And we saw from that prior paper, it seems like the more immunosuppression that you're on, the greater that risk could be. The reason we care about shingles is not so much just because of the rash, but because of the complications. And the most common complication is Posterpedic Neuralgia, which is pain that persists after that rash has resolved. And if you've known anyone with PHN, you know that at times it can be very severe, difficult to control, even with like opiates or nerve blocks. And so we want to prevent patients from having that complication. Other complications can include Ramsay-Hunt syndrome, stroke syndrome, herpes zoster ophthalmicus, or disseminated VZV, which we would see sometimes in our immunocompromised patient population. So there are two vaccines that were created for the prevention of herpes zoster. The first one was Zostavax, which was a live attenuated vaccine. And you can see here that in adults 60 years of age or older in the two pivotal trials, it demonstrated a 51% efficacy in preventing herpes zoster. And then the second trial, which looked at a younger population, 50 to 59 years of age, the efficacy was a little higher, around 70%. But since then, there's a newer vaccine, Shingrix. This is a subunit vaccine using glycoprotein E, and it uses a novel AS01B adjuvant. It's 2 doses, 2 to 6 months apart, but it can be shortened to 1 month interval in immunocompromised patients. And unlike Zostavax, which is a live attenuated vaccine, so again, cannot be given to immunocompromised patients, only immunocompetent patients, Shingrix is a subunit vaccine, so you can give it to immunocompromised and immunocompetent patients. And when you look at the efficacy with the populations and compare it to what we saw with Zostavax, Zoe 50 demonstrated a 97% efficacy in preventing shingles in adults 50 years of age or older. It demonstrated an 89% efficacy in preventing HC in adults 70 years of age or older. So the efficacy is just much higher than what we saw with Zostavax, which is why the CDC preferably recommended Shingrix over Zostavax. And because of decreased uptake of Zostavax, it's actually no longer available in the United States. The other thing that I wanted to point out is that Shingrix has been studied in the adult auto HCT patient population, where it showed a 68% efficacy. So Shingrix is recommended for all adults 50 years of age, 2 doses, 2 to 6 months apart. And what's updated for this year is that for adults 19 years of age or older who are immunocompromised or are shortly going to become immunocompromised, that they should also get Shingrix as well. And you can shorten that interval to 1 month. So for instance, if you want to complete it before they go to transplant or before they're going to get chemotherapy, that you can shorten that interval in those patient populations. So eligible patients should receive Shingrix regardless of whether they've had shingles in the past. They shouldn't get Shingrix during an acute episode, but after they've resolved, there's no specified time frame to wait. And they should receive it even if they have received Zostavax in the past. The other important thing just to keep in mind about Shingrix is that although it is a VZV vaccine, it was designed to prevent reactivation of VZV, so to prevent shingles. And it hasn't been evaluated. We don't know if a subunit vaccine can actually prevent primary infection with chickenpox or varicella. Other inactivated vaccines to keep in mind, the hepatitis vaccines, particularly in our liver transplant candidates, or really for all of our candidates, you know, if they were, for instance, to receive like a Hep B core antibody donor. So for Hep A vaccines, you can check a Hep A IgG to see if they're immune, and if they're not, to administer 2 doses 6 months apart. For Hep B vaccines, you can check a Hep B surface antibody. And if they're not immune, there's a couple of different options that are available. For transplant candidates, you can consider, you know, a single dose vaccine of like Engerix, one of the standard dose vaccines. For end-stage renal disease, the CDC actually recommends double dose. So that means giving 2 of those shots at each interval at 0, 1, and 6 months. There is a newer vaccine, Heplisab. It's a recombinant Hep B vaccine, CpG adjuvanted, which has a better immune response. And so the nice thing, in addition to a better immune response, is that it's 2 doses a month apart, and then you're done. Just the thing to keep in mind is that you want to make sure that it's covered by insurance, but I've been using more of Heplisab recently. And then if you can, you want to check a Hep B surface antibody a month after completing the vaccination series to assess for response. HPV vaccines are important to consider as well, because HPV vaccines don't just prevent infection, they're also anti-cancer vaccines, as is the Hep B vaccine. And then Tdap, tetanus, diphtheria, pertussis, you want to update every 10 years. And then Dr. Blumberg will go over the SARS-CoV-2 vaccines. So now that we've talked about the inactivated vaccines, I just wanted to touch upon the live virus vaccines. Remember, they can only be given pre-transplant. And here at Penn, we routinely check serologies to see if they're immune. So mumps, we're talking about MMR and Varivax. So we check mumps, rubella, varicella, IgG immune status. And if they're non-immune, then discuss with the transplant teams about vaccinating them prior to transplant. For MMR, if they're not immune to one or more of the components, you could either give them 2 doses 28 days apart, or what I typically do is to give a dose and then to assess for serologic response about a 1 month post-vaccination. Just a couple of things to keep in mind about the live virus vaccines. There's not a lot of data, and there's a concern that it could potentially cause harm to the fetus, so you want to avoid it in pregnant females. And then also that blood products, because the antibodies in blood products may potentially bind to components of the vaccine and diminish the vaccine response. So typically you want to administer them greater than or equal to 2 weeks before receipt of a blood product, or if they've received a blood product, and the different ones are listed here. If you can, you might want to wait 3 to 11 months, depending on what they received, just to optimize vaccine response. And then for varicella vaccine, currently, as I'd mentioned, the only one that we have is a live virus vaccine, Varivax. It's 2 doses, 4 to 8 months apart, and the same things apply. We should try to avoid them in pregnant females. And again, blood products may diminish this vaccine response. The last thing that I just wanted to mention is that some of our transplant candidates and recipients may ask about traveling. And when they are traveling, it's important to consider, whether they need to see either a travel clinic or an ID provider for any travel vaccines. So this is a nice resource that I like. So whenever one of the transplant candidates or recipients knows where they're traveling to, if you type in the country, CDC, and Travelers Health, you can get an idea of what vaccines and other things you might want to consider for the patient. So for Vietnam, you can see here, these are like the standard vaccines. And then it also includes travel vaccines like typhoid, as well as considerations, for example, for malaria prophylaxis. So usually the travel vaccines that come up are yellow fever, typhoid vaccines, and meningitis vaccines. So yellow fever is a live attenuated vaccine. There are certain countries that will require it for entry or recommended, but it is a live attenuated vaccine and cannot be given post-transplant. For typhoid, if they do need a typhoid vaccine, there are two options that are available. There's the oral typhoid, which is a live attenuated. It's 4 doses every other day, but the pills have to be refrigerated, so it needs to be completed before traveling, and that will last for 5 years. Whereas the intramuscular injection is an inactivated, so it can be given to our transplant recipients, and that will last for 2 years. And then depending on where they're traveling, if they're traveling to sub-Saharan Africa in the meningitis belts between December to June, or if they're considering traveling as part of the Hajj, they might need meningitis vaccines as well. So just in summary of this presentation, just a few key points to take away. We talked about how transplant recipients really are at increased risk for infection because of their immunosuppression. And so it's very important that these patients are up to date with their vaccinations to try and minimize their infection risk. Currently, vaccine uptake in transplant populations is suboptimal, and so it's really important to think about this as we're seeing these patients. The discussions regarding vaccination should start pre-transplant, because we know if we're able to give them vaccines prior to transplant, that they'll have a much better response than given post-transplant. And that live virus vaccines like MMR and Varivax cannot be given post-transplant because of potential safety concerns. And then lastly, just consideration of travel vaccines depending on where they will be traveling. So that concludes my talk, and I'm happy to answer any questions. Thanks so much for your attention.
Great, thank you so much, Ingi. I'm going to share my screen now, and we'll be talking today now about COVID vaccines. These are my disclosures, and none of them are actually relevant to this talk. It's hard for me to actually consider this, but we're now over 2 years into the pandemic, and I think we have to acknowledge that while we were really concerned about the numbers back in the late spring of 2020, we've really seen a lot more cases since then. The good news is that while the cases continue to mount, the actual consequences of this disease have actually been less than we saw initially, as death rates and hospitalizations have declined relative to the number of cases we're seeing. But the transplant population remains a particularly vulnerable group. And when we think about both our candidates and recipients, these are the people who are most concerning when it comes to acquiring COVID-19. COVID-19 has clearly been associated with higher mortality and increased hospitalization in both waitlisted patients and transplant recipients. But there is one thing we can do, and that is to vaccinate. If we look here at the actual impact of vaccination on the population at large, one of the things that's quite notable is even with all of the different variants that have come up, vaccines do make a difference, decreasing both the rates of actual infection and decreasing substantially the risk of dying from COVID-19. I think at this point, most people actually are familiar with how the vaccines work. Mostly, we're looking at using mRNA vaccines, as the adenovirus vector vaccine in the United States has certainly not been the preferred vaccine in transplant recipients, nor has it been as readily available. Both mRNA vaccines, once injected, actually enter an antigen-presenting cell, and where they're quickly annexed with the ribosome to allow for the development of spike proteins, which upon extrusion from the cell prompt both cellular and humoral responses, allowing then for protection by prompting the immune response when the individual who's been vaccinated next is exposed to the vaccine. Adenovirus vector vaccines have slightly different mechanisms in terms of what happens inside the cell, but the long-term outcome is the same in terms of prompting both cellular and humoral immune responses. You probably heard in the past week that we may be looking at yet another vaccine type in the United States, and that's the Novovax, which is actually a specifically complex spike protein, which can be directly injected and then taken up by cells to create this same vaccine response. Well, how do we know if a vaccine is working? Well, we can look at both clinical responses and laboratory responses, and I'm going to talk a little bit more about both of them. But the third thing that we definitely want to examine is adverse events. It's pretty clear in the United States that the interest in tracking safety in these cases where these vaccines were not fully approved, but approved under emergency use authorization, has been a major push. For those of us who were vaccinated in December, January, February of 2020 to 2021, we were asked to actually track our symptoms in something called the Vaccine Adverse Event Reporting System, which was an early warning system, and VSafe, which is text messaging, which was a voluntary registry that many of us participated in. But in addition to these two things, we also know that there were two other surveillance vaccine registries, the Vaccine Safety Data Link, which looked at results of vaccination in 9 integrated healthcare organizations, and CISA, which was actually a project that involved 7 medical research centers with vaccine safety experts that was especially interested in looking at pregnancy outcomes in these individuals. What we learned pretty quickly was that while there were a lot of adverse events just related to injection itself, including pain at the injection site, fatigue, headache, myalgias, chills, and in fact, in some cases, even mild flu-like symptoms, additional more severe adverse events were quite rare, including anaphylaxis, myocarditis associated with the mRNA vaccine, primarily in younger men, vaccine-induced thrombotic thrombocytopenia, which was primarily seen with adenovirus vector vaccines in women between ages 30 and 49, and neurologic effects, including Guillain-Barré. Interestingly enough, there was a delayed cutaneous response, and there are photographs here where people would sometimes get back tremendous areas of erythema and induration that then might occur with the second vaccine or not occur at all. Regardless, these symptoms were minor and did not actually rise to the level of concern related to future vaccination. So we were able to focus on really clinical endpoints. Now, remember, initially, what these studies looked at were efficacy. In other words, how well did the vaccines perform clinically in an environment that was completely controlled? I'm going to be talking in a little bit about effectiveness, which is actually how well the vaccine has performed in real world situations. But to sort of think about this to begin with, we really have to think about what we're expecting the vaccine to do. Initially, we'd like to see it prevent infection, prevent symptomatic disease, prevent hospital admission, prevent severe diseases manifested by ICU admission, and prevention of death. What would be really outstanding also would be to prevent transmission. And in fact, these vaccines performed very well in early clinical settings with the alpha virus variant. Unfortunately, as the variants have gotten more capable of escaping some of the immune responses, what we've discovered is they're not quite as good at preventing infection and disease or transmission, but they've been really outstanding at preventing more severe consequences, including ICU admissions, hospital admissions, and death. And so there's still a lot to be said, even though the actual ability to fully prevent disease is not quite what we had seen in the original studies. Now, there's been a lot of interest in looking at vaccine responses by measuring antibody. And I will say that this is something we actively discourage and in fact is not recommended by the FDA. Why is this? Well, antibody is a complicated thing. It turns out that the antibody test availability includes greater than 50 FDA EUA approved tests. In other words, things that have been approved under emergency use authorization. Very few of these actually look at antibody to the receptor binding domain, to the spike protein itself, which is actually the thing that's measured when you look at a vaccination. So unless you're looking specifically at RBD specific antibodies, you're not actually examining antibody response to the vaccine itself. But it's even more complicated because the different platforms have different sensitivity, specificity, predictive value. They look at different immunoglobulin isotypes. They target different antigens, and they particularly measure, in most cases, binding antibody, which does not specifically correlate with whether or not you're going to be protected against the infection. Some rare assays can look at neutralizing, which is a little bit better, but it's important also to recognize that both antibody and cellular responses may be important to protect us against COVID and its more severe consequences. And none of these assays measure cellular responses, nor are antibody responses predictive of the cellular response. Finally, it's important to notice that there are no specific definitions for what constitutes protective levels. So if you're thinking that an antibody is going to tell you whether your patient is protected, I would advise you to actually avoid doing that because it will be an incomplete measure at best. So let's look at the history of these vaccines and where they've been and where they're going and why we're now talking about multiple doses when initially we were just talking about a primary series. When the vaccines were initially released in the winter of 2020 to 2021, what we saw was they had performed incredibly well, actually historically well, in the initial vaccine trials, with efficacy rates of 94 to 95% with the mRNA vaccines, lower efficacy with the single dose of the Janssen & Janssen vaccine, the adenovirus, but actually it was still performing pretty well at preventing severe critical COVID-19 when one looked at it. But unfortunately, the response rates in immunosuppressed hosts were not as good. And in particular, organ transplant recipients not only had lower antibody responses, but they also seemed to do not quite as well in terms of protection against disease. But I would caution you that we can't say that one size fits all for any transplant recipient. It's important to recognize that each recipient comes to transplant with a different underlying immunologic risk. Age plays an important role in terms of our ability to respond to vaccines, and certainly people over 65 have lesser responses than those under 65. The time from transplant plays an enormous part in how you respond to vaccination, the specific immunosuppressive regimen someone is on, how good their renal function is, and what their other comorbidities are. For example, are they diabetic? Are they morbidly obese? Things of that sort may play an important role. It's also important to recognize that the patients themselves vary in terms of responses based on the organs they've received. And traditionally, liver transplant recipients have had better responses than those who've received thoracic organs. And in part, while this may be true related to the types of immunosuppression they're on, it's probably not quite as simple as that. What are the factors that have been associated with particularly poor responses? Well, the most important one probably is immunosuppression. We know that individuals on triple therapy, those on anti-metabolites, especially mycophenolate, those receiving higher dose steroids, and especially important, those receiving depleting antibodies, including rituximab and anti-thymocyte globulin, and individuals on belatacept are going to be particularly poor vaccine candidates. The more recent the transplant, the less likely they are to respond as well. Individuals with hypogammaglobulinemia, lower GFRs, and older age are also less likely to respond. So let's think about how we can enhance vaccine responses. One of the most important things we can do is vaccinate individuals before they get to transplant, because it's clear that even individuals like who are on dialysis or those with chronic kidney disease are going to have much better responses to vaccine, despite the fact that they don't have normal immune systems related to their chronic kidney disease. There are some things we can't change. For example, the underlying immunologic risks, the age, time from transplant, and their comorbidities. But there are other things that we may be able to do. We can, in addition to immunizing them prior to transplant in those individuals in whom that's still possible, we may be able to consider immunosuppression modification. Now, I don't think this is anything that we should be doing at this point on our own. There's certainly some clinical trials that are going to help us understand which agents might be safely adjusted for which patients and how long those adjustments will be required. So for now, I wouldn't recommend it, but I think in the near future, we'll probably have some data that will help us to think about how to best address this. We also can give additional doses of vaccines, and I'm going to start to talk about that next. In particular, the recommendation for redosing with a third dose of vaccine that came out in August 2021, fourth dose vaccines, which were recommended as of January of this year, and the later recommendation of giving fifth doses. So let's talk about the benefits of a third dose. It turns out that in many populations, less than 50% of individuals are going to respond to 2 doses alone. And in the study that's shown on the left-hand side of the screen from France, they actually were able to give a population that was mostly kidney transplant patients for a third dose of vaccine 1 month, at least 1 month after the second dose. And in some cases, it was much longer than that. And what they found was antibody responses increased dramatically, so that by that point of the third vaccine, they actually were seeing response rates in an additional 20 to 30% of their patients. So they'd raise the response rates to the high 60s or 70%. But what did this mean in terms of a more robust response from a cellular and neutralizing antibody standpoint? Well, investigators at the University of Toronto actually did a prospective controlled trial where they compared a third dose of vaccine to placebo in individuals who had already received 2 doses of vaccine. And what they were able to show was those individuals who had actually only received 2 doses of vaccine, who then went on to get a third dose, had better antibody responses in terms of measurable IgG, better neutralizing responses, and actually evidence of an improved cellular response as well, suggesting that a third dose of vaccine should be given to all. And in fact, there was effectiveness data to go along with this. In other words, not only was this an immune response that could be measured, but they actually started to see that 3 doses actually resulted in a lower rate of COVID-19 in the population, both in terms of infection as well as clinically important outcomes of hospitalization and death. Additionally, it became clear that individuals who had been well vaccinated were less likely to get COVID-19 from their household contacts, suggesting that there was benefit beyond that of just their own otherwise control. But it wasn't perfect by any means, and clearly in solid organ transplant recipients more than the general population, breakthrough infections started to be seen. Now, we don't actually know the full incidence of this, but we do know that it's higher than in people with normal immune systems. The confounding variables in these studies have had to do with numbers of doses of vaccination, time from vaccination, the difficulty in accounting for both numerator and denominator data. And what's most important now is the impact of variants. In general, these breakthrough infections were more likely to be asymptomatic or minor, but they did have some cases in which patients had more severe disease and death. And clearly, the breakthrough infections were more likely to occur in household settings where they had a household member who had COVID-19. One of the things that we've learned that I think is going to be one of the most important take-home lessons, though, is breakthroughs are probably reflecting the circulating variants. And what we've seen now, especially in the setting of Omicron and in Delta, that these variants were less likely to be avoided in people who had been vaccinated with the current vaccines. It's important to note that breakthrough infections do occur in normal hosts. And if you've been talking to any of your friends, relatives, in addition to your patients, you're probably hearing that the vaccinated people are now getting COVID-19. Why is this happening? Well, we know that the response to vaccine is not permanent and that over a matter of months, there's actually a waning both in total antibody and neutralizing antibody, and this probably also is reflected in immediate cellular responses too. In the transplant population, it's clear that within 3 months, we also are starting to see this waning of neutralizing antibodies, and by 6 months, there's been a significant decrease in both IgG responses and T cell responses when looked at as a composite variable. So what's going on here? Well, I think we have to acknowledge that what we're seeing is not just a waning of immunity overall, but an inability to address some of the newer variants. And for those of you who aren't really thinking about this, I just want to define the variants for you. So basically, a variant is basically a specific group of mutations that causes the virus to behave differently than the original strain. So in other words, it's enough mutations to change the distinct portion of the genetic code. These variants are notable because they may be more transmissible, more deadly, or less susceptible to vaccine. And you may hear 3 different terms: a variant of interest, which is notable for its local impact, a variant of concern, which has global impact, and a variant of high consequence, which significantly reduces preventive and therapeutic countermeasures. And the Omicron variants would certainly fall into this category. What's the current status of variants in the United States? Well, currently we're living in the BA2 and BA2.12 variants as our major variants that we're seeing now. But on the horizon, we fully expect to see the BA4 and 5 that are coming in now from South Africa, and these seem to be even more transmissible than the current Omicron variants we're seeing. This is something to be concerned about for all of us because it's very clear that the Omicron variants we've seen, these BA1, 2, and 2.12, have actually posed a problem even for the normal host. And here are 2 articles from the New England Journal that actually show that when compared with Delta, individuals who've been vaccinated are still more likely to get infected with the Omicron variants than we had seen in the past. And this is especially true for individuals who are over 60 years of age. This then prompted the recommendation for 4th doses of vaccine in healthcare workers who are at risk, as was done in Israel, and is now being recommended for both adults over 65 as well as others who may be at increased risk. And what you can see from the additional doses is while there's still some concern that they're not quite as immunogenic against the Omicron variants, they certainly are significant boosts that seem to be associated with improved protection from both infection and more severe illness. How does that translate to transplant recipients? Well, it turns out that the 4th dose in transplant recipients also seems to have some benefit in boosting immune responses. And in particular, it has some benefit against neutralization, although again, neutralization against Omicron, which is notable for being in this lower panel here, is actually something which we're still not ideally seeing in transplant recipients. So that then prompted this consideration of actually giving 5th doses to vaccine in solid organ transplant recipients. And the data here is really quite limited, but does suggest that at least some individuals, perhaps even the majority of people who are given a 5th dose of vaccine, may at least have increased antibody, and whether that will translate to better protection from infection or at least more severe disease, we'll still have to wait to see. So where does that leave us in terms of vaccine schedules? Well, this is a schedule for individuals who are not on immune suppression. In general, for adults who are 18 years and older, or for children 5 years and older with the Pfizer vaccine, the recommendation is to give the 2 doses of the mRNA vaccine with at least 1 boost at 3 to 8 weeks for children with the Pfizer or anyone older than age 5, and for 4 to 8 weeks with Mrna vaccine. So at this point, fully vaccinated does mean 3 doses of mRNA vaccine. The interval between the primary series, so those initial 2 doses of mRNA vaccine, and the booster is about 5 months or more. Now, in individuals who've gotten J&J vaccine, I think we're still going to be seeing some changes, but at this point, everybody should have gotten at least 2 doses of vaccine. And it is probably preferable that if they got a J&J vaccine for their first dose, that the second dose should be an mRNA vaccine to improve vaccine uptake. What about for the solid organ transplant patients? Well, I'd like you to think about their primary series being a 3-dose series. So for the Pfizer, and we do prefer the mRNA vaccine in this population, as it's clearly been shown to be more immunogenic. And so all primary mRNA dose vaccines should be 3 doses. So they get the first dose of a Pfizer, then they get a second dose 3 weeks later, and then 4 weeks later for Pfizer, they get their third dose, and that is the primary. For the Mrna vaccine, the only difference is the first 2 doses are separated by 4 weeks, and then the third dose would be 4 weeks later. Now, it's very important to realize the Mrna vaccine, that third dose should be the full dose vaccine, not the half dose. It's generally considered to be the booster. Everybody then should be getting a 4th dose boosted 3 months later, and should be consideration for a 5th dose now 4 months after the 4th dose. But I think we have to acknowledge that while this is going to improve vaccine responses, it's not going to be perfect. And as these newer variants come along, we may need to wait for newer variant vaccines to help us be better protected. So what can we do in the meantime? I think we need to still counsel our patients that the vaccine is not their opportunity to completely ignore all common sense guidelines. And that means masking when they're indoors, outside of their bubble, and social distancing. It's very important for ring vaccination. What does that mean? The people in their circle should be fully vaccinated as well. And then the last option in terms of this protection are new monoclonal antibodies. Currently, tixagevimab, silgavimab, otherwise known as Evusheld, has been recommended for prevention of SARS-CoV-2. This is the original clinical trial that did not look at immunosuppressed people, but looked at normal hosts who had not been vaccinated. And what you can see is there was enhanced protection when compared to placebo using this monoclonal antibody. Based on that, and based on the limited supply of this product, the recommendation then became to give this product to people who were moderately or severely immunocompromised, who might not mount an adequate immune response to the current vaccines, or who could not get the vaccines because they had had severe allergic reactions to it, the prior vaccine. Notably, this is only allowable for adults or adolescents aged 12 years and older, weighing at least 88 pounds. And so that's not a product that's currently available for most pediatric populations. The highest priority individuals are really those who are most likely to either have severe consequences of infection or those individuals who are least likely to respond. So here at Penn, our first tier priority are lung transplant recipients, anybody who's received depleting antibodies, individuals who've had to be treated with pulse dose steroids within the prior 3 months, all individuals less than 1 year from transplant. In fact, we're trying to vaccinate people before they leave after their transplant admission, and anybody who's on belatacept. There are very few contraindications to this in the adult population, but 2 that you should be aware of is it cannot be given to somebody who currently has COVID-19. While there's some data that may come out about this as a treatment algorithm, right now there's no data to suggest in the solid organ transplant patient population that this will have benefit. Additionally, it has not been used as preemptive prophylaxis for somebody who's been in recent close contact with somebody with COVID-19. We simply don't know if it's going to work. And as I mentioned before, it's not available for children. Generally speaking, the adverse events have been quite minor, with the major one being injection site discomfort. It's 2 large injections in the buttocks, and it's really not actually very comfortable. But it says more severe reactions, including allergy, fatigue, chills, nausea, vomiting, sweating, muscle aches, and lightheadedness, have actually been very minor and not usually reported. The biggest concern were cardiac events reported in that original clinical trial. The number of cardiac events was extremely small and potentially greater in people with underlying cardiac disease. But in general, we've not felt that the data has been suggestive that this has a really important signal. And as it's been given more widely, there haven't been increasing reports of this. What about timing with respect to vaccination? Generally speaking, we think that this monoclonal will actually blunt vaccine responses. And so if somebody is actually due for a vaccination, it's better to update their vaccine and then give this 2 weeks later. If they've already gotten this and you want to know about timing of vaccination, I think that's going to have to be decided on a person-by-person basis in terms of when they're due, what their prior vaccination status was, and what their specific immune suppression was. In those individuals who've just been transplanted, we're waiting at least a month before we update their vaccines if they're due. I will caution you that it's quite possible that in several months from now, we may not still be using this monoclonal, and that's why they took away the recommendation for redosing at this point and are waiting to see what will happen. It's not clear how well it's going to perform against upcoming variants. If you're looking to find this for your patients, there's actually a COVID-19 therapeutics locator, which can actually be found that's really been developed by the federal government that tells you exactly where these doses can be given. Unfortunately, we're still seeing an enormous amount of vaccine hesitancy in the United States. And in fact, there were over 80 million doses of vaccine that were recently wasted because they hadn't been given. And so I think we have to acknowledge that we need to do a better job getting vaccine out there, because while it's not perfect, it certainly has made a big difference in terms of everybody's lives. So where do we stand now? Well, vaccinations are recommended for all kidney transplant recipients and all transplant recipients in general. It's preferable to vaccinate prior to transplant for everybody, regardless of what type of transplant they're going to have. And post-transplant, we typically delay, as Ingi said, timing for about a month, but now we've been giving the monoclonal to people in the hospital, and so we're delaying at least a month. The schedule for transplant recipients now includes 5 doses, 3-dose primary series. Remember, for Mrna, that means they need to have the full dose, not a half dose for the 3rd dose, with 2 boosters. Currently, we're not recommending any alteration in immune suppression in anticipation of vaccination, and we would also not delay a transplant simply to complete a series. Especially important, household and close contacts should be vaccinated to create greater ring of protection. And I would recommend that you continue to tell your transplant recipients to continue to observe safe living guidelines with masking, preferably with KN94s or N95s, social distancing, avoiding crowds, indoor crowds especially, and hand washing. We have posted on our website very up-to-date guidelines that are including therapeutics guidelines, as well as we've been working hard to work with the American Society of Transplantation to update those recommendations for all things COVID as well. And I'll be happy to take questions as well. This is my contact information if you have any questions. So I'm going to stop sharing my screen, and then Ingi and I will be happy to take any questions that you might have. So people, I do want to point out one thing, Ingi, that I wonder if you could address that was brought up initially, which is how to address the vaccine issue when many patients only show up at their providers when they're sick.
Yeah, I think that's a tricky situation, but I think as part of that discussion, if they do have an opportunity to see you, you might not have to vaccinate them at that visit, but at least have the discussions about what vaccines that they should consider getting. Because even if they can't get it then, once their acute issues have resolved, they could also go to like a local pharmacy as well and get their vaccines there.
And as Ingi wrote in the text, the Novovax, the CDC Advisory Committee will be meeting. You know, unfortunately, we don't have any data in terms of this in terms of real world effectiveness yet in transplant, but it'll be good to have another opportunity, because heterologous boosting may ultimately help.
I think Rose also had another question. So would you recommend fourth and fifth booster doses for those who are on the wait list for transplant?
Currently, most of them don't qualify under the EUA unless they're already on immune suppression. I would certainly try to make sure that anybody who qualifies for the fourth dose get it if they are eligible. But the EUA is pretty specific. Now, these vaccines, the standard dosing is actually now allowed. The Pfizer vaccine is fully approved as a, and so we're going to have more opportunity to do this. But I think anybody who falls under a rubric of immunocompromised, I would continue to vaccinate them. We're hoping to see a variant vaccine. Moderna just released some information about that they're going to be sharing data with the FDA about their variant vaccine. And I think we are going to be getting that. The fourth shot is actually only eligible right now. That data was from Israel, and I'm sorry if I was confusing, but it's really recommended specifically for individuals who either have immune suppression or who meet the age qualifications, which I believe is 65.
I think a fourth shot is 50 years.
Or me, oh, I'm sorry, you're right.
Yes.
Angie, I thank you for correcting.
Yep.
Yeah, so anybody 50 and older can get a fourth shot. We already sent an MPM out to providers about the fifth shot and to patients, and I will make sure that that actually has gone over, but I put something out, our group put something out in May about the fifth shot, but we'll make sure, because we had both the fifth shot and Evusheld information in the last MPM.
Should we wait for the fall to get the fifth shot?
I don't think I would wait, because we actually have no idea when that's going to be. And also, you know, whether or not, so if you're eligible for a fifth shot, if the patients are eligible, I would probably do that now. You know, I think we may say something different come August for people due for fifth shots then, but anybody who's due for a fifth shot now, you know, there probably will be some benefit, even if it's not perfect, against the variants that we're expecting coming around the corner, because BA4 and 5 are supposed to be even more transmissible than the current Omicron variants.
If there are no other questions, then we can wrap up the session. Thank you, Dr. Blumberg and Dr. Lee, for that informative session, and thank you to our guests for joining us this evening.